Welcome to Expert Second Opinion, Current and Future Roles of Immunotherapy and Targeted Therapy in the Management of Advanced Gastroesophageal Cancers. These are excerpts from a meeting we had January 9th at the GI ASCO meeting in San Francisco. The meeting was moderated by Dr. Sam Klempner from the Massachusetts General Hospital in Boston, and faculty members included Drs. Jaffer Ajani from the MD Anderson Cancer Center in Houston, Dr. Rutika Mehta from the Weill Cornell Medical Center in New York City, and Dr. John Strickler from the Duke University in Durham, North Carolina. In the presentations of the meeting, first, Dr. Ajani talked about HER2-targeted approaches to advanced GE cancers. Then Dr. Strickler talked about targeting Claudin 18.2. Dr. Mehta talked about immunotherapy strategies in these patients. And Dr. Klempner finished up with a talk on other novel agents and strategies being considered in patients with these tumors. We had 4 sessions focused on questions and cases that were collected from a survey of 50 community-based general medical oncologists. And to begin, Dr. Klempner presented a case submitted by one of these physicians.
I'm going to start by asking you the question that you've probably been asked in some form multiple times at this meeting, which is, you've got this case, in this case a young patient with metastatic gastric cancer, HER2 positive, also PD-L1 positive with a CPS score of 2. And you just presented the Horizon GEA, so if all of this stuff was available to you right now, what would you do clinically?
Yeah, so, I'll make sure that the patient can tolerate the IO, and I'll give all 3 drugs, or all 3 components. So it will be zanidatamab, tislelizumab, and chemotherapy. There's no reason to consider pembro or nivo, because today, when I have a HER2-positive patient, I use Keynote 811, and I don't, instead of pembro, I'm not looking for nivo or tislelizumab. So in the Horizon trial, why should I substitute tislelizumab to any other?
Yeah, I think this is probably one of the more important questions of the whole thing and what many people are wondering about given the positive phase 3. And John, you've done tons of HER2 agents. You've done tucatinib. You've participated in this. So what is your sort of top-line impression of the data, and what would you do if this was available to you?
So I think that's the key statement. What if it were actually available to me? And that can be a challenge sometimes with novel therapies to be able to access them in the clinic. I think we need to stick with what we know from Horizon GEA-01. What we know with near certainty is that zanidatamab is superior to trastuzumab. Okay, there are still some gaps in our knowledge because the control arm was not a modern control arm in that it was not a Keynote 811 backbone. But I feel like based on the evidence, zanidatamab belongs in the treatment algorithm for a patient with HER2-positive metastatic gastroesophageal cancer. What is also intriguing about this data, and what surprises me in a way, is how little PD-L1 status seemed to matter with zanidatamab in Horizon GEA-01. And that one is tough to figure out. And in the back of my mind, I enjoyed, Jaffer, your talk, because I do wonder if it's novel mechanism of action, the different ways it's causing cytotoxicity, which appear to be immune-mediated, maybe that is potentially a mechanistic explanation for why PD-L1 status doesn't matter for zanidatamab, where it does matter for trastuzumab. And I'm curious if is that what your interpretation of that data is?
So I don't think we have a very good answer.
Right.
But data certainly support the use of zanidatamab in PD-L1 negative versus positive. Till we digest this and discuss among ourselves several times, I think currently I would just follow the data.
And Rutika, what about you? You're obviously on these papers. You have experience clinically with Zani. What about your sort of top line? You feel the same as Jaffer and John?
I concur with Jaffer and John. I think this is practice changing for sure. Zani is way superior than trastuzumab. There's no doubt about it. I know Jaffer didn't have a chance to touch upon toxicities due to time limitations, but I think diarrhea is a significant toxicity, but probably manageable with the chemo backbone that we would plan to use.
Yeah, John, comment.
I think it's very important to emphasize the toxicity component because especially when we bring a new drug into the clinic, there's always a learning curve. And the key thing that I've really zeroed in on is we know that zanidatamab increases rates of diarrhea. However, through that phase 2 open label experience, they learned how to very successfully manage that in a way that preserved the activity of zanidatamab and improved the tolerability. And specifically in cycle 1, the first 7 days of cycle 1, there's mandatory loperamide twice a day for 7 days. And with that intervention, interestingly, although diarrhea was common in the zanidatamab arms of Horizon GEA, it did not appear to lead to treatment discontinuation of Zani. And I do think it's because that diarrhea is front-loaded in that first cycle, and it's because they did institute that measure in that study. So something very important for all of us to keep in mind as we bring this into the clinic.
Yeah, I totally agree. I mean, implementation of this is going to require a little bit of a learning curve, but diarrhea is something that I think as oncologists we all have familiarity with managing, as well as nausea and other common symptoms.
Right.
Jaffer, I'm going to come back to you on this second case because you mentioned 811. So a little bit atypical here, also a younger patient with advanced HER2 positive, PD-L1 positive disease. Prior to coming to a new practice, got FLOT times 3 with looks like doesn't get any biologics with the FLOT and had stable disease, maybe a little bit unusual not to have any response. Transition to a new practice. In this scenario, in the current day, with what you have available to you right now, would you continue the FLOT backbone or would you migrate more towards traditional 811?
Yeah. So I would never use FLOT in metastatic setting. And I know there was a study comparing FLOT-like regimen to FOLFOX, and FLOT-like regimen was a little bit better. The hazard ratio was about 0.8. The advantage was very minor. The toxicity is much more. So metastatic patients are more symptomatic than localized patients, and they're more deficient in nourishment. So I would stay away from FLOT. In this case, if this patient came to me with those biomarkers, again, I'll make sure that they can handle Pembro, and I'll just use Keynote regimen.
Yeah, I agree. I think if you've got active biologic agent like this, the additional benefit of a taxane in this scenario is probably quite limited. Rutika, just real quickly, your thoughts as well?
Yeah, I agree. I would never do FLOT in this situation unless and until there was a curative intent treatment planned for this patient and you have finite treatment cycles planned for this patient. I would use FOLFOX backbone with Pembro and trastuzumab.
All right, let's get to a couple more cases because we've got a bunch and then some good questions that have come in. So now you've got a little bit other end of the age spectrum. You've got an 80 and 87-year-old patient here. HER2 positive patient, a lot of liver mets. We see that pattern in HER2 positive patients periodically, nodes and liver. Clearly is symptomatic from their cancer, weight loss, poor performance status. What are you doing in this first-line scenario? John, you also brought up, sort of the importance of managing toxicity. So someone who's maybe a little bit more borderline.
Yeah, this is the art of medicine, not the science, right? And we'll never have a trial where we can randomize 500 patients to either arm and answer this question. I think the question for me is, what can this patient handle? What's the patient's goals, right? So an 80-year-old clearly is, so deconditioned by her illness that she may be on the verge of being admitted. So I think it's, first of all, just starting with a frank discussion about what that patient's goals are, what are their sources of support. If we give an aggressive treatment, do we have support around from other family members, neighbors? So if the patient is wanting to be as aggressive as possible, what we've got here are some actionable biomarkers. When I see HER2 positive, I'm hoping it's IHC3+. Assuming it's PD-L1 positive, I think the first question is, could this patient take, is the heart function good enough to take trastuzumab, right? Or even a Zani, but I think, assuming access is limited, it might be trastuzumab. And then you would love to get in a situation where you could potentially give Pembro and add that in, right? And then the question is, what cytotoxic could you put on top? And I might start with a chemo-free and just kind of slowly layer in the cytotoxics. If that patient's performance status improves as I'm layering on those treatment, that's telling me that performance status is limited due to disease, right? So the more I can kind of take away and kind of eat away at that disease, the better that person will feel. But if that performance status is low due to baseline comorbidities, I'm not going to make that person feel better or live longer by giving FOLFOX with trastuzumab and pembro. So, yeah, that's why I say it's an art of medicine, not a science.
Yeah, I agree. I think, the biologic-only lead-in is interesting. We saw an older phase 2 from Dr. Janjigian looking at this, and they had a few patients that did this approach, and it was like a third of patients that had some response even after just the biologic doublet. Right. Rutika, I'm going to come to you. So sort of same question, spinning it, but let's say a patient is a little bit fitter, maybe like the second case. We've seen data on empiric dose reductions in older or more frail patients from this old go-to randomized trial in elderly or frail with CAPOX. What kind of FOLFOX dosing do you do or think about? Talk about the bolus, your platinum and 5-FU kind of dosing.
So my chemotherapy backbone is typically FOLFOX, and I universally don't do 5-FU bolus in metastatic settings. If I have a patient probably older than 75, I'm typically reducing the dose of oxaliplatin to about 65 milligram per meter square rather than 85 milligram per meter square. Unless and until they're extremely fit, they're kind of walking like a 50-year-old, that would be a different aspect. But that's typically my FOLFOX dosing for majority of the patients that are elderly. In the second case that you have here, looks like the patient did not receive oxaliplatin, just 5-FU, pembro, and trastuzumab with borderline functional status. Borderline could have different implications, but if we're talking about, like in the first case, bordering on ECOG of 3, then again, goals of care discussion is warranted here because clearly the patient was not even fit enough to get oxaliplatin in the first-line setting. I would probably have a goals of care discussion.
And Jaffer, so similar questions to you about your sort of FOLFOX dosing, but let's take the second case a bit and 2 questions. So let's say this person is still fit. Are you going to biopsy them at the time of progression? In the original DG01, it wasn't needed, and the label doesn't require it, but it recommends it. And in DG04, we saw that everybody required to have a biopsy before going on TDXD. So maybe if you don't mind commenting on the case like that.
So I think, it's hard to answer when you have description like this on paper because you really have to see the patient. Already progressed on first-line treatment. So I would, FDA also recommends repeating HER2 status, but I wouldn't consider this, unless the primary is in place and there's another reason to do an endoscopy, etc. Might do a liquid biopsy, but whether to treat with TDXD will be a very difficult question to answer for this patient with this age. So you could consider just single agent taxane or irinotecan, or have a long discussion and see if they just want supportive care.
Yeah. And then real quickly for all of you, and then we'll go to the next cases. Let's say Zani was available to you now also. Would you have concerns about both of these patients? Would you say, hey, it's our best drug, we're going to give it because response is going to be important? So, Rutika, you can get first crack quickly. If Zani were available to you, kind of yes, no for both cases.
Yeah, if I'm a purist and a clinical trialist, PS of 2 or more were not included in the trial, I would probably hold off on treating them with Zani at this time, unless more experience is gained by treating other patients with Zani and kind of trying to understand the nuances of how to manage these side effects. I would not be comfortable offering Zani tomorrow to these 2 patients.
And John, same questions to you, and then Jaffer.
For the first patient, that's not the first patient I would ever treat in my clinic with Zani. Okay, maybe the 5th, but not the first. I think while Zani is clearly more active than trastuzumab, it does have greater rates of diarrhea and GI toxicity, and you just want to make sure that person has adequate support around to handle dehydration. Someone will call the office, make sure she comes in for fluids. So yeah, I'd like to get a little more experience with the drug before I start doing it in those scenarios. For me, the 87-year-old male case in the second-line setting brings up all kinds of interesting questions because, clearly I would not give Zani in that case because now we're in the second line. But the question is, what's the role for TDXD here and rebiopsy? I think there has been some very interesting work done out of Japan showing that in these elderly and frail patients, that approved dose of 6.4 mg per kg is not necessary in this group of patients, that a lower dose is probably not sacrificing much in the way of activity and is likely better tolerated. So I would think about maybe a circulating tumor DNA to confirm HER2 amplification in blood, and if I gave TDXD, it would be at that lower dose in that particular scenario.
Jaffer,
sorry.
You can comment, but maybe for the sake of time, we'll just go to the next one.
Yeah.
I actually have a practical question for you all. Let's say Zani is available to you, and John, you mentioned the 7-day lead-in of scheduled Imodium, but do you envision sort of in your practice having someone call the patient on day 8 and check in? Because could you not extend the Imodium if they were having diarrhea, for example? How are you going to formally structure this? And Jaffer, I'll start with you.
Yeah, so I wanted to mention that Zani, as a single agent, the rate of diarrhea is very low. Also with taxane, it's very low. And the study that I showed, the first study that I showed, this was the scenario there. Patient already had trastuzumab treatment, and then they got Zani and got about 30% response rate. So having said all that, I would still like to see the patient before you give the next treatment. Yeah.
Awesome. And then this is something I think we all encounter. So this is essentially a case of someone who has really no visceral metastases, but some non-regional lymph nodes, where technically by the TNM criteria, this would be a 4A or 4 patient, so they are stage 4, but this is an otherwise fit 52-year-old, highly HER2 positive, highly PD-L1 positive, interested in pursuing aggressive strategies even outside sort of the standards of care. And Rutika, I'll let you start off with this case. How would you approach someone? You've got 2 good biomarkers, it's technically a stage 4 patient. We do have these patients out there.
Yeah, I think it's GE junction adenocarcinoma. If we're looking at a curative intent treatment for this individual, then I would have the patient meet with the surgeon, probably also do a staging laparoscopy to see if they're peritoneal disease. But as you mentioned, this is a clinical stage 4 disease. I would vote on doing biomarker-driven therapy with Keynote 811 if Zani is not yet available, but if we're able to use Zani in a parallel universe, then of course we'll go with the Horizon GEA treatment backbone.
Nice. And Jaffer, same question, but how long would you give neoadjuvant therapy before you would think about a surgery? Let's say they have a clinical CR, or maybe they have a residual disease on a primary on endoscopy.
That's right. So I think this is the type of case I usually take to my multidisciplinary, even before treatment starts. And then we usually get the recommendation of systemic therapy. So as Rutika mentioned, I would do Keynote 811, not do Durva-Flot because this is not the right situation for that. And then reassess and retake them to multidisciplinary conference, and then what we call consolidation at a later date, either with radiation or radiation plus surgery or surgery first, etc.
And John, so just my own editorial comment, when I get GE junction cancer and I'm HER2 positive, I would like to get HER2-directed therapy in the non-metastatic setting. But John, this case, we see these, how do you guys do it? Similar to...
Yeah, this is actually not an uncommon scenario.
Yeah.
We see this quite a bit. And our general approach, number one, it is stage 4 disease. It's systemic disease, but it's fairly limited in its extent. But I would give this patient the best, who's relatively fit, robust, and wants an active therapy. I would give them the best available therapy. I think this is an excellent, if I had access to it, I think this would be an excellent patient for a Horizon GEA regimen. Chemo, Zani, and tislelizumab. Now, I think it is a fair critique to say that while there was a survival benefit with tislelizumab in this study, there was in the control arm there was no immunotherapy, right? And the question is, well, what's the value of tislelizumab? And I think Jaffer got to the real crux of the matter. If you look at a couple of different markers, it looks like tislelizumab is doing something in this trial that we're not yet capturing on this first interim survival analysis. The first is you see a pretty dramatic increase in the median duration of response when you add in the tislelizumab. So in somebody like this, I think that means something. That matters to be able to get not just a response, but a long-term durable response with good tolerability. Additionally, you do see those landmarks. Like there does appear to be a tail forming on that tislelizumab arm that looks to be a little bit more impressive to me. So I'm, in the absence of a great control arm, I'm relying on my clinical judgment and my interpretation of that evidence. Now, what do? So we generate a response, and you come out to 6 months. What we do routinely at my center is we will have an endoscopic evaluation of the primary. We will biopsy that site. I would not be surprised if you had a complete response in the primary, in which case you're good. We'd look at this, assess whether that's viable or not. If there's still some viable disease, we may radiate that supraclav node. But we're looking for what's left, and we may radiate some oligometastatic disease in that scenario.
Yeah, I think it is not that uncommon of a scenario as we get better biologic therapies. Rutika, this is basically two variations on the same theme, which is in someone with localized, operable, HER2-positive cancer, are you tempted to migrate the targeted agents and the metastatic regimens, which are very active, into the non-metastatic space? You can talk a little bit about some of the phase 2 data that we know exists, but do you think we're ready for this?
Not yet, I would say. Wish we were, but although how promising we've seen with the metastatic setting, I don't think it's prime time to move them into the locally advanced setting. We've seen the HER2 FLOT data, but again, a randomized phase 3 study in the locally advanced setting for HER2-positive disease is still pending. So until that time comes, I would still use FLOT plus durvalumab as a perioperative treatment strategy.
And Jaffer, same question to you.
Yeah.
And maybe just for the audience, tell a little bit about what's been done in the non-metastatic with the HER2, like the FER-FLOT and et cetera.
That's right. So there are a couple of studies, one from China and the other one European, where the PAT-CR rate is pretty high. So if you got HER2, perhaps 3+, PD-L1 positive, and you treat you direct therapy to HER2 and PD-L1, you can get a very high PAT-CR rate, and some patients will do very well for a long time. But I think we cannot recommend that on a regular basis. This is something to keep in mind, because this patient, when they develop metastatic disease, which is highly likely, then I think you come back to HER2, but not initially.
Yeah. And John, I'm going to end this HER2 module by asking you the question that probably people have asked you, like, if Zani is available and you've got Pembro and you've got Nivo and you've got Tisli available, do you care about the PD-1 that goes with the Zani?
There is no evidence that one PD-1 is better than the other, right? So for me, I consider them to be interchangeable.
Yeah, agree. Totally agree.
This concludes our program. Special thanks to our faculty, and thank you for listening. This is Dr. Neil Love for Expert Second Opinion, Current and Future Roles of Immunotherapy and Targeted Treatment in the Management of Advanced Gastroesophageal Cancers.